Hi everyone. I last week I reviewed over the chapter and I got some really good positive feedback on that. So I want to do that again this week. And I also want to check in on you and see how you're doing. As usual, I'm going to be talking really fast so that I don't take up too much of your time. I apologize if you hear my son in the background. So this is week 6. Check in, chapter review. So first of all, I want to see, how are you feeling? Are you taking care of yourself? I love this quote. It says, "Do something nice for yourself today. Find some quiet, sit in some stillness, breathe. Put your problems on pause. You deserve a break." I think we all deserve a break. So this week we're talking about the abdominal assessment. So this is just a really good picture for you to get an idea of where the parts are, the organs in the belly, and to kind of really know what quadrant things are in. And I think this is pretty much just a review from when you were in nursing school. So this popped out at me as I was reading it because I am going through these lessons right along with you, making sure that everything is working correctly. Um, there are many specific procedures and maneuvers involved with this system. So be sure you know what each is and what it means clinically. So I did take down some videos that I thought would be helpful for you because it's one thing to read stuff, it's another thing to actually see it being done. And also, I noticed there is on one of the questions when you're flipping through on the order in which you assess the abdomen, osculate, percuss, palpate. Um, it tells you that when you click on the correct one, it tells you it's incorrect and then reads it back to you as it is the correct one. So there's a glitch there, and I have sent that off to IT to be repaired. Um, so here's your abdominal structures by quadrant. So again, you want to know what quad all your structures are in. Um, and this is really long, and I'm not going to go through it all. But these are things that you want to ask the patient when they come in with abdominal pain. And this is just if you're a mnemonics person, which I am, old cart, I love my mnemonics. This one happens to be Socrates, which is site or location, onset, character, radiation, associated symptoms, palliative or provoking, the timing, typo, exacerbating, and the severity. Past medical, surgical, social history are very, very important. Um, this was a quote that I pulled from NIH. Skilled clinician, this is out of context, but most of the time, a skilled clinician can identify the source of abdominal pain by the history alone, 80 to 90% of the time. So, really important that you get that history. So there's different types of pain. Visceral pain is usually organ pain. It's usually a gnawing, cramping, or aching pain. It's often difficult to localize. It's all over the place. Kind of think hepatitis, like the whole belly hurts. Parietal pain is irritation of the peritoneal lining, and that's much more severe, and it's usually easy to locate. Think of appendicitis. Referred pain, this is when it originates at a different site, but because it shares innervation from the same spinal level, it goes to a different site. So, for example, you have gallbladder pain, which is felt in the shoulder. I can tell you from experience, I had an issue with my gallbladder, and I was totally convinced, me, the cardiac NP, convinced I was having a heart attack, and made my sister get up in the middle of the night and bring me to the hospital. Turns out it was my gallbladder. So, maneuvers. This is rebound tenderness, and the important thing about this, I gotta move my picture so you can see this better. There we go. The pain is upon release, not when you're pushing down.
Rebound tenderness is an important sign indicating peritoneal irritation. The palpating hand is slowly and gently pressed deeply into the abdomen, then quickly released. If peritoneal irritation exists, the maneuver is quite painful. Ask the patient where the pain is most intense. Okay, Tom, at this point in time, I'm going to check rebound tenderness in the abdomen. I'm going to palpate gently but deeply with quick release and checking for any pain with that.
So when she pulls back quickly, that's when the pain will happen.
Rebound tenderness is an important sign.
Like I said, I am not really good at this. Okay. Another one is Rovsing sign. And we'll watch this one. And again, this is when they have pain in the right lower quadrant, despite the fact that the pressing was on the left.
Acute appendicitis is a key cause of acute abdominal pain, particularly in adolescents and young adults. It affects approximately 7% of the population, so being able to diagnose a condition effectively and rapidly is really important. For a full discussion on how appendicitis presents, make sure you check out our video series on acute appendicitis. But in this video, we're going to focus on one of the key diagnostic examination findings that we should look to elicit in someone who has acute appendicitis, and that's Rovsing sign. Rovsing sign describes when the patient is palpated in the left iliac fossa, and this results in pain in their right iliac fossa. It occurs as a result of the inflamed appendix irritating the overlying parietal peritoneum. So as we palpate the left iliac fossa, it causes the parietal peritoneum to stretch. And as the peritoneum overlying the appendicitis is already inflamed, this stretching results in the patient experiencing pain in the right iliac fossa. If you enjoyed what...
So as you can see, he pushed on the left, but the patient grabbed to the right because that's where they had the pain. Let's see, heel strike. There are no videos for this, and I actually have not ever used this, but if you have the patient stand with their legs straight and rise up on their toes and then relax with the heel dropping down to the floor, it jars the body a little bit, and that can cause pain. Alternatively, which would be more likely, you could have them laying on the bed there and take the surface of their heel and hit it with your fist. You can't see me. Hit it with your fist, and they'll have pain with that. The obturator sign, pains elicited by an inward rotation of the hip with the knee bent. So, and that's because the obturator internus muscle is stretched, and she does a really nice job of this.
The obturator sign is another sign of appendiceal irritation. The internal obturator muscle lies close to the appendix on the right. When this muscle is stretched in the setting of an acute appendicitis, the patient experiences increased right lower quadrant pain. To perform this test, flex the patient's leg at the hip and the knee, then internally rotate the hip. This stretches the internal obturator muscle. Okay, Tom, I'm going to flex the knee and the hip and internally rotate, and let me know if you have any pain with that. The obturator sign.
The psoas sign is the hand on the patient's thigh just above the knee, and ask the patient to raise the thigh against your hand, and this will also cause pain.
A positive psoas sign is another indicator of acute appendicitis. The appendix lies close to the iliopsoas muscle, so if the appendix is inflamed, any maneuver that tenses or stretches the iliopsoas muscle may result in increased right lower quadrant pain. There are two ways to test this psoas sign. One way is to have the patient try to flex the right hip by raising the right leg against the resistance of your hand. Tom, I'm going to have you raise your right leg against my resistance, and let me know if you have any pain. The second way to test the psoas sign is to have the patient roll onto his left side, then grasp the right leg and extend it at the hip. This stretches the psoas muscle. Increased right lower quadrant pain with either of these maneuvers is a positive psoas sign. Tom, I'm going to have you roll on your left side. And I'm going to extend your leg And let me know if you have any pain with this. Okay. You can turn back over on your back.
Okay. Murphy's sign is looking at an inflamed gallbladder. I'm just
A
flying through
positive
this.
Murphy's sign is an indication of gallbladder inflammation and may also indicate inflammation of the liver. There are several ways to check for Murphy's sign. You may hook your fingers or thumb around the right costal margin and ask the patient to take a deep breath. If he winces or interrupts inspiration because of right upper quadrant pain, this is a positive Murphy sign. Another way to check for gallbladder or liver inflammation is to use indirect fist percussion, comparing the amount of pain in the left to the right. Okay, Tom, I'm going to curl my thumb under your rib cage and take a deep breath for me. Let me know if you have any pain with that.
No.
Okay. Next, I'm going to curl my fingers and take another deep breath for me. Let me know if you have any pain with that. In the indirect fist percussion, let me know if you have any difference in pain from the left to the right.
No.
Okay.
A positive Murphy sign is an
So I think that is the bulk of what I had for you there. And then just going over again, same thing as I said last week. When you're going through this chapter, if you see something in a different color like this, blue, then you want to pay attention to that and focus your eyes on that a little bit. Again, here it's showing you the different quadrants and where the organs are. Let's see, your health history approach again. And these are some common concerning symptoms of issues that your patients are going to be coming in with GI complaints. I mean, that's one of the most common complaints you're going to get in the office. Information, again, that you want to get, and I think we went over this already. You can either use Oldcart, you can use Socrates, but you really want to make sure that you get the past medical, surgical, and social history because, again, 80 to 90% of the time, the answer is right there. Again, you're looking at the red. It's reminding you about the visceral pain in the right upper quadrant, suggests liver distension. Right lower quadrant, you're looking at the appendix. So you want to, red, your eyes should be being drawn to that. And I know these are really huge chapters and you've all got really busy lives and that's why I'm trying to help you. The blue and the red, you really want to know this stuff. This is what you want. Your eyes should be being drawn to that. Heliobacter pylori was something that I had not really heard a lot about in my schooling. And then I did some practice in primary care with geriatrics and had a patient who I kept treating her for peptic ulcer disease, and come to find out H. pylori. I finally because it wasn't responding, so I said I'm going to test her for H. pylori, and sure enough, it was positive. Treated her for the H. pylori, and lo and behold, she got better. So all these little things are important that you keep them in memory. You're not going to keep everything in memory, but even little tidbits that will at some point you'll be like something's in the back of your head, and so you know to go and look it up. There is nobody on this planet that can remember absolutely every single thing, which is why you just need to remember the key points and know where to find the information. So again, left lower quadrant pain with diarrhea and constipation, thinking about diverticulitis. Diverticulitis can go between constipation and diarrhea back and forth. Very, very painful. GERD, is very common. Let's see, dysphagia. This is stuff you want. Again, you want to read this. It's in red. Changes in bowel functions should always kind of get your head working. What's going on here? Is this just a common diet? Change? Did they eat something bad? Did they go out and have some bad fish? Or is something more important going on? So you want to read this stuff. Nocturnal diarrhea is usually pathologic. So that's, again, it's in red. So these are things that you don't want to just poo poo off. You want to pay attention to these things. Um, jaundice, excuse me, jaundice, is as a nurse, it's the yellowish discoloration of the skin and the sclera. Usually makes you think liver. Um, let's see. Again, risk factors for liver, urinary symptoms. Um, again, you have stress incontinence, bladder infections, UTIs, cystitis, acute prostatitis. Interesting case, patient couldn't urinate and felt like she had to but couldn't. Got really painful in the middle of the night, went off to the emergency room. Past medical history included some cancer, and ultrasound showed she had a large tumor that was blocking the urethra, and that's why she couldn't pee. So a catheter was put in, she was able to pee, and unfortunately, oncology was called. Let's see. Hematuria, rhabdomyolysis. As nurses, I'm sure you've heard of that. And, if your diabetic comes in and is saying, I hurt everywhere, I feel like I've been hit by a Mack truck, and they have some pink urine, you may want to kind of think about that a little bit. Flank pain, is it kidney pain? Is it ureteral pain? Tips for examining the abdomen. You want to know how to do this because, like I said, you're going to get a lot of patients in the offices that have GI complaints, and you're going to be doing a lot of abdominal exams. So, looking through all this, it's not blue, it's not red, but it is purple. It's not black. If it's not black, make sure you're looking at it and assimilating that into your train of thought. Again, they show you pictures, but I think the videos are much more informative as far as how to do that exam. And your poor families, practice on your families, because that way when you go into the room with the patients, you're super comfortable because you've done it on your brother, sister, boyfriend, husband, wife, several times. Children, my poor daughter was my um, victim every time I had to practice something. Again, you're looking. This one here is the palpating for the splenic edge. You want to practice this one because it's at least for me, it was a little tricky. I had to do it quite a few times before I finally got the hang of it. This kind of helps you here, as you can see. I should have looked for a video for that, but you guys can do that. I'm sure you'll find one. These pictures, you really need to see it actually being done. But I'll let you do that. YouTube. Let's see, anything else here? Special techniques. This is always looking for ascites. That's always a good one. You'll find some of your heart failure patients, their bellies will just be full of fluid, as well as your liver patients. Let's see. I really think I've kept you guys for quite a while. So pay attention to how do you record your exam. You want to make sure you're documenting it correctly. I'm just going to kind of fly through here. I don't think there's too much more. Like, this is really huge. You're never going to remember all of this stuff. But really focus on the big things that your most common ailments that you're going to see. So when a patient comes in with a GI problem, you want to rule out the worst case scenario first. And then after that, look at your most common ones. Okay, I don't want to just say go over the most common ones, because first you want to rule out the worst possible scenario. Get that off the table. And then look at the most common issues. And I'm going to kind of let you go at that, because I think this has gotten quite long and I don't want to take up this much of your time. If you have any questions, concerns, specific questions, please reach out. That's what I'm here for. I do try to get right back to you. Have a great week, and to remember, take some time for yourself and to breathe.